It's with pleasure that I introduce Dr. Sumith Mathew from the Christian Medical College in Vellore. Sumith is an associate professor of the clinical pharmacology unit at Christian Medical College, or CMC, in Vellore, India. And he is leading the anti-infectives TDM program at the hospital, and his research interests look at model-informed precision dosing in critical care units within the hospital. And of course, he's interested in pharmacokinetic modeling, looking at some clinical trial work on antibiotic TDM, and development of devices which can facilitate availability of TDM in routine patient care. So, Sumit, pleasure to have you here.
Dear friends, good afternoon. I'm here to present the topic, this model-informed precision dosing of colistin. I'm thankful to Dr. Menino and the organizing team for finding the topic appropriate for this annual precision dosing seminar. And unfortunately, I missed all the fun of being there in person to deliver this talk. In this topic, I will give a brief explanation of the pharmacokinetics of colistin and the role of model-informed precision dosing in the management of patients with colistin. And after this talk of Dr. Paul, he actually rightly pointed out how far behind India and other low middle income countries are in antibiotic monitoring and getting MIC reports, etc. So we have a huge task on our shoulders to take antibiotic TDM forward in India. This colistin is used to treat gram-negative carbapenem-resistant infections, and it has high nephrotoxic and neurotoxic potential. It is administered as a colistin sodium. It's a prodrug and is spontaneously converted to colistin. It has high inter-individual variation in pharmacokinetics, and the recommended therapeutic AUC is 24-hour AUC is 15 mg per liter. We have performed a study on colistin pharmacokinetics and its influence on clinical outcome with financial support from Indian Council of Medical Research. And this was a prospective observational study. And the study was conducted in multiple phases. In phase A, a simplified colistin model for routine clinical use was developed. In phase B, factors associated with colistin-induced AKI, acute kidney injury, were explored. And in phase C, the relationship between colistin exposure and clinical outcome was assessed. In phase A colistin model was developed using P-matrix. 45 patients were included for model development and was externally validated on 13 patients. One compartment model with zero order input and first order elimination best described observed concentrations of colistin. Addition of a lung compartment for those who received inhalational colistin did not improve predictions, and therefore we assumed that the penetration of colistin into lung is poor. And we identified creatinine clearance calculated using Jelif equation and serum albumin as covariates on elimination rate constant. The day 6 24-hour AUC was predicted for all the patients who received CM's colistin sodium for more than 6 days. And the individual variation for this day 6 AUC was 80%. So colistin exposure was predicted over a period of 6 days in patients who received colistin sodium for more than 6 days. And all these 22 patients received a loading dose of 9 million international units. However, it took 96 hours for the median predictions to fall in steady state after receiving a loading dose of colistin sodium. In phase B of the study, we identified the role of genetic variants affecting transporters PEPT1, PEPT2, and P-glycoprotein. in predisposition to acute kidney injury. The genetic score was calculated using the information on the presence of these genetic variants, and an ROC cutoff of 0.1283 was identified for predicting acute kidney injury on day 7 of treatment or day 7 of treatment. And based on this information, patients were classified into high predisposition and low predisposition. High predisposition to acute kidney injury and low predisposition to acute kidney injury. And patients with high predisposition to acute kidney injury constituted 12.7% of patients recruited for the study. And we identified a lower AUC cutoff of 48.5 milligram per liter in patients with high predisposition, compared to a cutoff of 66.5 in patients with low predisposition. Therefore, we propose two different targets for patients with high and low predisposition to colistin-induced AKI, which is 40 and 60 respectively. In this study, we identified high colistin exposure, presence of genetic variants, and the number of co-administered nephrotoxic drugs as significant factors predisposing to colistin-induced AKI. In phase C of the study, we determined the influence of colistin AUC on clinical outcome. And this was performed with the assistance of colistin PK model and best dose. All patients received meropenem along with colistin sodium, and none of them developed AKI. And this may be probably due to the reduction of colistin sodium dose when colistin exposures were reported to be high. 22 patients were recruited for the study. And among them, 13 attained target AUC by MIC of more than 50 for at least 2 out of 7 days. And out of them, 92% improved clinically within 7 days. On the other hand, among those who did not attain target, 55.6% improved clinically within 7 days. This relatively high proportion of clinical improvement among those who did not attain target may be due to the synergistic effect of co-administered meropenem. Therefore, early therapeutic drug monitoring may improve clinical outcome early in the course of colistin treatment among critically ill patients. Colistin seems to be an antibiotic suitable for target concentration intervention. Toxicities were rarely observed in our study when the predicted day 6 AUCs were less than 40. And the higher the AUC by MIC, there may be better chance for clinical success, especially in treatment of deep-seated infections. For example, if the MIC of the organism is less than 0.25 milligram per liter, and if we continue to keep the target AUC as at 40 milligram per liter, then the fraction or the free fraction AUC by MIC will be approximately 80, because roughly 50% of colistin is bound to proteins. And this concentration of unbound colistin in systemic circulation may be good enough to treat a deep-seated lung infection. So we suggest to target an AUC of 40 to 60, 40 or 60 in the early days of treatment with colistin till the MIC of the organism is determined, at least till that. So we propose colistin target concentrations based on the findings of study of Chia et al. And based on the genetic predisposition study, which is under review, the study is under review. We propose a target of 40, a target AUC of 40, and for those with low predisposition, we propose a target AUC of 60 milligram per liter. For example, if the MIC of the organism is less than 1, when we target an AUC of 60 for low predisposition group, it corresponds to an AUC by MIC of 60, and considering the free fraction of colistin as 50%, it results in an AUC by MIC of 30. And according to the study of Chia et al., this AUC will be bactericidal. Similarly, if the MIC of the organism is less than 2, patients with high predisposition to colistin-induced nephrotoxicity will be able to receive only bacteriostatic FAUC by MIC for certain strains of bacteria. And those with low predisposition could still be treated with bactericidal FAUC by MIC. But none of these fraction AUC by MICs are good enough to treat lung infections for organism with an MIC of more than 1. We have not initiated active TDM for all patients admitted in critical care units, but we have initiated discussions towards implementing model-informed precision dosing for routine patient care. And here is the planned workflow for personalized antibiotic care. The ICU technical assistant provides patient information, which includes dosing regimen and dose timings of antibiotics in real time to the antibiotic TDM team. The TDM consultant goes through this information and identify patients who need TDM of antibiotics. And this is informed to the antibiotic TDM lead, and the ICU registrar is contacted to discuss the case. Once decided to initiate the model-informed precision dosing process, the ICU registrar supervises time, blood collection, and the whole process will happen within 48 hours of starting the new antibiotic. Within 24 hours, report and recommendations for dose optimization is given to the ICU consultant, who will take the final decision with or without discussing with ID physician. And within 5 days, we will follow up the patient and review the MIC report. We may discuss this with the clinical microbiologist. We do repeat measurement of antibiotic concentrations, and after reviewing the clinical status of patient, we will suggest dose optimization. And the schedule for follow-up is maintained by the TDM consultant. So in summary, we observed a high individual variability in colistin pharmacokinetics. High colistin levels can predispose to nephrotoxicity and neurotoxicity. People are genetically predisposed to colistin-induced renal injury. We may have to aim for different targets for patients with different genetic constitution. So if you identify that a patient is having high predisposition to colistin-induced AKI, you can actually switch over to some other antibiotic. And these antibiotic targets should be confirmed in future clinical trials. We observed a higher probability of clinical cure in patients who attain target AUC of colistin. And colistin dose should be optimized early in the treatment period. And this MIPD of anti-infectives need team play. I'm extremely thankful for my team in clinical pharmacology who helped me with these studies, and we are looking forward to initiating the proposed MIPD for colistin. I especially thank my colleague, Sumith Mathew, and Dr. for help I received towards conducting these studies. And for the funding we received from Indian Council of Medical Research. And thank you.